Now, Dr. Levy, what does this mean? A zero point 0.2 interval to 0.3, or sometimes I'm reading it as 200 milliseconds to 300 milliseconds. This change, first of all, are we seeing this change in sort of the baseline acceptable level in any other areas of medicine? Has this been a broad change in all people getting their hearts looked at?
No, not at all. This is a single arbitrary decision on the part of the FAA to move the goalpost back so that what was previously clearly abnormal is now considered, if not abnormal, not worthy of additional testing. And that ultimately is, I think, what we come to. I can't completely read what the FAA is thinking and doing,
right.
But the logical conclusion is, why would you suddenly change an EKG parameter that's been set for 100 years and has been the standard by which cardiologists have read EKGs and how we understand the conduction system of the heart? Why would they suddenly, in the last few months of the pandemic, after which a lot of people have had COVID, after which a lot of people have received vaccines, both of which can put chronic spike protein presence into your body, either one or both, why would they suddenly move this back unless they were obviously getting a whole lot more people who are either pilots or potential pilots now have this aggravating new change on their EKG and they don't want to be bothered with testing? The problem is, yes, a person as they get older can gradually develop this change. But when you have en masse, a whole definable population where a substantial number of people all of a sudden prolong that PR interval, that indicates a good possibility of significant conduction system disease in the heart. And what does that mean? That means an increased chance of arrhythmia. That means an increased chance of heart block and going either into a simple or a fatal arrhythmia. And it's also been clearly associated with, in this one study at Harvard, a 50% increase in mortality of all causes. So this is serious business. And it doesn't mean anybody's likely to drop dead as a rule. But as you said with Josh, we're dealing with planes full of people here, and we can't be monkeying around with the heart like this. We had, before the pandemic, as a cardiologist, an entity called myocarditis. Muscle, cardio, heart, itis, inflammation. Inflammation of the heart muscle. In 40 years as a cardiologist, 15 years actively practicing many years ago, high volume of referrals, I saw one case of myocarditis in my life, in my professional career. Now it's routine for many cardiologists to have a number of these patients on board. A lot of docs and cardiologists are sort of just not wanting to pay attention to these slight elevations of troponin. But these slight elevations of troponin, especially after somebody has been sick for an extended period of time, can indicate potentially a deadly degree of inflammation in a focal part of the heart that affects the conduction system. And the problem is, heart cells are electrically active cells. And when you put them in a situation where they lose blood supply or they become inflamed, they become electrically unstable. And so, football player, pilot, you have stressful situations, a sudden surge of adrenaline or epinephrine, and next thing you know, that irritable pack of cells in the heart throw extra beats, and you could go and you could have a benign abnormal heart rhythm, or you could have a deadly heart rhythm. So this needs to be paid attention to, in my professional opinion, not just the pilots, but I think everybody should get a troponin and D-dimer and make doggone sure it's not abnormal, because there do exist a subset of people where they've pretty much come back to clinical normalcy, but they still have this low-grade myocarditis that needs to be knocked out completely. And by knocked out completely, I mean bring those tests back into the normal range.